Joining me on this new Speaking of Women's Health podcast episode is one of our favorite Center for Specialized Women's Health nurses, Marissa Walker. And I think somewhere in the background, Beth, you want to pop up? Beth is my daily nurse that works with me with patients. Where are you hiding, Beth? There she is. I love these ladies. They're so great. So a little bit about Marissa. She has her Bachelor's of Science in Nursing, and she is a registered nurse, and she is a nurse in the Center for Specialized Women's Health at Cleveland Clinic in our OBGYN and Women's Health Institute. Marissa is a mother of two boys. She's a boy mom like I am, and her boys are so cute. You just want to pinch them. They've had fun meeting my granddaughters, and Marissa and I kind of share a guilty pleasure with nails, right?
Yes.
Yes. And sometimes we'll post both of our hands together on our Speaking of Women's Health social media. If you don't follow us on podcast, or if you don't follow Speaking of Women's Health on our Facebook or X, formerly known as Twitter, or Pinterest, or LinkedIn. We're also on YouTube and Rumble channels. So if you're listening to this podcast and you want to see Marissa and her pretty eyelashes, you're a girly girl. There, I see Beth sneaking out probably to get some patients ready for clinic. Anyway, welcome, Marissa. We're so excited to have you as a guest on the Speaking of Women's Health podcast to talk about a lot of the common questions that you field every day. You work as a facilitator with Dr. Bator's virtual shared medical visits. You work in triage. So tell us about some of the work that you do in our center and some of your areas of expertise.
Yeah, so background, I do have experience in emergency medicine, labor and delivery, and I've been in gynecology, women's health, menopause for the last 3 years now, coming up on 3 years. And it's been great.
You're a very smart cookie, and you also have expertise in helping a lot of our patients who get bone infusions, and you do nurse visits as well.
Yes.
Yes. So we're going to go over some of the common questions that I think you field most every day. So tell our listeners, what's the difference between getting a GYN annual exam and getting a pap smear?
Yes. Now this question is so common because I know back, not even about maybe 5 or 6 years ago, we used to get our PAPs and our annual exams at the same time every year, right? So, and because medicine is changing, these guidelines are changing, we have to change things up from time to time. So, common misconception is that you have to get a pap smear every year. So they found that you don't have to get it that often. A pap smear is a gynecological test that will screen for cervical cancer, and we tend to do it typically every 3 to 5 years. Now, an annual GYN exam, that's going to consist of your breast exam and your pelvic exam, and that will be done annually. It's the annual, yearly, every year. A pap smear is just something that may occur in one of those years, but not necessarily every year, unless there is something that needs to be followed up on.
And that is such an important point. And I find a lot of my patients think they had a pap smear simply because they saw a woman's health clinician or a gynecologist and had a speculum put in the vagina to look at their vagina and cervix. It doesn't mean that it was scraped. And for our listeners who haven't heard the interview I did with Dr. Sharon Sutherland, who is a gynecologist, and she's in charge of our cervical cancer prevention program and the head of our gynecology ultrasound, which we may talk also about since we order lots of pelvic ultrasounds. That's a good podcast to go back to listen to. And the thing that I emphasize to a lot of my patients and new patients, and I know that our whole team, like our administrative assistant, Julie Stahl, who's been on our podcast to talk about how to get an appointment at the Cleveland Clinic, is she'll send out messages on my chart asking people and women to bring in their records and bring in their actual pap smear results and keep copies so that we have them, because we can't see even if it's an electronic system of another system. Do you want to talk a little bit about my chart and how patients access and interact with you on my chart?
Yeah, so from time to time we'll get a phone call, and that will be through our admins. They'll leave us a message and we'll get back to them usually within 24 hours. And then if there's a question, non-urgent or non-emergent, a medical question, our patients will type in that question in my chart and we'll answer it. Now, sometimes it does take up to about 3 days to get a response, typically for that, because we have such a large patient flow. But we get questions that have to do with menopause concerns, like symptoms that one may be having, or questions about their medication, refills, trouble getting their medication from a pharmacy, pretty much anything. It's a large range of questions that we get.
Yeah, you get a whole wide variety. And I know that the other day when lead nurse Alexandra was there, she was like, there's not anyone in triage right now, and everybody's box is overflowing, and there's hundreds and hundreds of questions. And so our nurses just really work so hard. And that's one reason why I'm so grateful that we're able to put out so much great content on Speaking of Women's Health to empower women to be strong, be healthy, and be in charge. Because a lot of these answers, I bet people could go on our Speaking of Women's Health.com website and just type in and get some simple answers that they need, as opposed to overly relying on the nurses. And certainly for emergency situations, people need to call 911 or go to the emergency room for heavy bleeding, chest pain, those kind of things. I think it's very important for people to understand how to utilize electronic secure communications with their healthcare team. I do believe that the clinic has instituted sometimes charges for my charts. Is that?
That is correct. So if there's a my chart message that requires more time from the physician or from the advanced practitioner, then generally they will charge a certain amount to the patient's insurance. To answer that question, because it just kind of counts. It'll be equivocal to a telephone visit or a virtual visit almost, depending on how sensitive the question is.
Yes. And so that's why I think this podcast is so important, to go over a lot of questions that maybe people can get answered ahead of time and not have to, go online and wait, a few days to get an answer.
Yeah.
So this other common question is, my doctor states that my pap smear was normal, but on my chart it says yes for HPV reflex. What does HPV reflex mean, Nurse Marissa?
Yes. Okay, so HPV is a STI or STD that we test for generally when we do a pap. It's automatic for everyone after the age of 30 as of right now. So reflex just means in the event that something is abnormal, we will go and test for this item. So when you get that message that says, hey, yeah, your pap smear was normal, follow up in a year, you're fine to go, and you see the reflex, yes, HPV. It's just meaning that in the event that you would have had an abnormal pap smear, they would have saw some atypical cells, some cell irritation on the cervix, or some low-grade cells on the cervix, anything of that nature. They'll go ahead and test to see, is HPV the culprit of that? We'll test for it. But it doesn't necessarily mean that you have it. To indicate whether you have HPV, your actual HPV test, you'll see where it will say detected or not detected. You would go by that.
Excellent. That is so excellent. And most all women do get exposed to HPV, even if they only have one sexual partner. And most people clear the infection. So 80% of women have been exposed by age 50. But sometimes if your immune system's bad, it can come back out. There's other causes, especially in midlife women, of abnormal paps, particularly if they're low in hormones. The cells can look abnormal. So it's very important to get this periodically checked. And I'm a big proponent, and I know a lot of our APPs, like we've had nurse practitioner Dana Leslie on in the past, and I think hopefully we'll have her on in season 3 again. And we've had other nurse practitioners who are excellent, like Kelsey Kennedy and Babs, Alex Babushkak as well, to talk about their advanced practice nursing practice. And we usually try to do a PAP every 3 years. Like I was just in to see Dana myself, because 5 years is a long time. And so I think if women have gone definitely more than 3 years before they've had the scrape and the HPV, that they should talk to their women's health team about, well, maybe I should get another one, because maybe they won't come back within that 5-year mark. And we really do not want to miss cervical cancer for sure.
Mm-hmm.
So let's move on to the upper part of the bikini area, the breast area. And a lot of women, I'm sure that you talk to all the time, are having breast pain and they wonder if they need a mammogram. And so talk a little bit about how you handle that from a nursing perspective.
Yes. So I think it's just like a common misconception, like as soon as you have any type of breast pain, you need to automatically get a mammogram. Like, that's not the case. Like, Cleveland Clinic, we have a very impressive breast center. So when someone is having pain in like these locations, we have these specialized centers for like almost every body part here. So we do have a specialized breast center, which we do like from time to time network with and trade notes with. So in the event that you have breast pain, we wouldn't automatically give an ultrasound or a mammogram. And I didn't want patients to think that it's neglectful on our part not to give you a mammogram because you have breast pain, right? Because it could be due to anything, and we want you to get that thoroughly checked out. So in general, we would generally refer you over to the breast center to get further follow-up. Like, yes, a GYN can look at breast and pelvic, but if you want someone that specializes in it to get a more detailed examination and like diagnosis and referral to what you need, it would be recommended to go to breast center. So generally we'll start with that.
And one thing, of course, it can be from hormonal fluctuations. I've seen a lot of women, since we've been checking omega-3s and seeing a lot of people are getting too much of the inflammatory omega-6 fats and not enough of the omega-3s, that a lot of women are just taking fish oil. And we've got podcasts on nutrition and diet and omega-3s. And I've seen women develop breast cyst and breast pain from too much omega-3s, even though a lot of people don't have enough, and just hormonal fluctuations, wearing a good support bra. And so that doesn't necessarily mean cancer, but we have new legal requirements in Ohio law in terms of reporting out on mammograms. And so I'm sure you're going to, if you're not already getting lots of questions from women, it's getting much more detailed about whether their breasts are dense or not, whether they are at increased risk for breast cancer, whether they should have more imaging. And there's a lot of women who kind of fall in this gray zone. And I'm sure that's going to generate a lot of confusion and questions. And I really like to direct to our patients to our speakingofwomenshealth.com site, because we have a lot of proactive information about breast health, reducing breast cancer risk, and who are those high-risk people who do maybe need more imaging like ultrasound or MRI, or maybe even need to see cancer genetics. And we do have a large population in our center of women that have genetic mutations that do make them at higher risk for breast and ovarian cancer. So let's move on to another really common question I know you get asked all the time is, if I've had a hysterectomy and I don't have a uterus or cervix, do I even need to come in for an annual GYN exam?
Yes, that's very common too. Yes. So the short answer would be yes, you do. Because the annual exam does consist of both breast and pelvic and vaginal exams. So I do tell my patients, just like flat out, like uncandid, like even though you don't have a uterus, you still have a vagina. So like
and a vulva.
Yes, and a vulva, and you're still prone
and a bladder.
to get any of these items. You can still get any type of infection. Like, you still engage in intercourse, and you may have some problems, like gynecological issues, and you want to be established with a provider and see them every year so that you can be up to date on your exam, so we know what's going on. And then when you have a question or a problem does arise, we're not like scavenging and looking around for someone to see you right away when you have someone and you've been seeing them yearly. So yeah, it's very important. Like we see people, everyone, even if you don't have a uterus.
Yeah, you're still a woman.
Yes.
And checking muscle tone, rectal exams, maybe colorectal cancer screenings, which if you didn't listen to our March of 2024 podcast on colorectal cancer screening, we're seeing that skyrocket. And we're starting to screen a lot younger women, like 45 or even earlier. And you can't see certain parts of your skin, also weight and blood pressure and, lab results, medication refills. A lot of people, I think, are busy. They don't want to have to come in and pay a copay, and they just want to get their refills. So what's kind of your guidelines on how you handle when women call in for asking for refills for birth control pills or hormones or other medications?
A lot of the time, we understand that life gets in the way sometimes and things come up. So a lot of the time, we'll offer, like, for example, if someone needs a refill on their birth control or HRT, if they've been seen very close to about a year ago, We usually will pen a temporary refill to that patient, but we do ask that they schedule an appointment, have one on the books within about 3 months, because that's the longest like a refill will go, especially with like a mail order pharmacy, to get that fill in, just to have enough time and give you adequate time to schedule. And then when you go to your follow-up appointment, you'll get the remainder of your refills.
Yeah, that's very important. I know I certainly myself, as soon as I have that appointment, whether it's with the eye doctor or with women's health or primary care, I make the next year's appointment so that it's within that 365-day mark, because there's no guarantee that somebody will get the prescription. And I just think to be proactive. I mean, it's great that you nurses help the patients out, but I know that if they don't come in for appointments, then the prescriptions do get canceled. So that's a little bit of a cautionary tale.
Mm-hmm.
So moving on to the women on hormone therapy, my field, patients many times might remark, well, I'm on the estrogen and the progesterone, and I love the estrogen, but I don't like how that progesterone sometimes makes me feel. So is it okay, Nurse Marissa, if I just stop the progesterone?
No, absolutely not. Especially if you have a history of endometriosis or if you have a uterus, because we do not want any changes to that lining that can lead to, we don't like to say the C word, but we don't want anything to lead to any type of gynecological cancer. So if you feel like that progesterone just is not working for you and you just need to stop it, you need to stop the patch or the pill also, the estrogen patch or the estrogen pill also, because you want to protect that uterus.
Absolutely. That is such important advice. And I even have nurses and physicians who you think would be, more up on, of course, health in medicine do that. So all patients we treat the same, and we want to have that high level of care for. And that's why I think it's good to bring in all your medicines, not just say, oh, look in the chart, because there can be a lot of changes about how it's dispensed from the pharmacy, how the woman takes it, and to be very proactive, even also with supplements, is important too. And you have been listening to the Speaking of Women's Health podcast. I'm your host, the executive director of National Speaking of Women's Health, and with me is one of our absolute favorite nurses, Nurse Marissa Walker, who is a registered nurse, does a lot of triage, does nurse visits, helps our entire team. And we're talking about common questions. And she says we don't like to have to say the C word, which is cancer, but we always have to rule that out if there's problems. And that gets us to the B word, bleeding. And I know that you, and certainly I, handle so many messages and calls about bleeding. And women will tell us, well, I just missed my dose, or I was traveling, or my patch fell off, and then I bled. So that's the reason, right? But what does that buy them, so to speak, in terms of your responses?
A lot of times, so we can't ever rule out that there may be anything wrong. It can be anywhere from a fibroid to a polyp, some changes in your lining, once again, too thick of a lining in the uterus. So we do want to just rule out any changes that we can nip in the bud right away that may cause the bleeding. Also, just to piggyback off of that question, a lot of people will say, well, I had bleeding, but it stopped, so I'm good. I'm good. I can just stay on my. I'm like, no. We still recommend to either schedule a follow-up exam, or you may have imaging done. Anything called a SIS, a pelvic ultrasound. SIS is like a saline infused ultrasound, where we look into that endometrial cavity and we see if there are any abnormal structures in the uterus or in that lining there. And then from there, we'll see what we have to do after that, like if anything needs to be removed or if it's healthy for you to continue the HRT or hormone replacement therapy.
Or maybe needs to be dose adjusted for women who can't even tolerate natural progesterone, which is a small percent of women. Sometimes we use designer hormones like Duave, but we can't make hormone changes, especially in a woman over 40, if there's a possibility of cancer or infection or anatomical structural changes. And I know that's annoying to have to undergo it. I've certainly undergone ultrasounds and biopsies in the office and DNCs. It's just unfortunately sometimes part of being a woman, and we have to woman up and deal with it. And I know that a lot of our patients try to kind of beg you nice nurses, oh, it's really okay, and they just want your reassurance. And most of the time it is okay, but we just can't do that, because we've all seen examples and we don't want to miss things and regret it down the road. So I really appreciate you nurses being so understanding and educational, but pleasant and firm. And it's kind of how you have to be sometimes with your children, right?
Yeah. Definitely.
Yes, yes. So moving on to the pap smear results, I know a lot of people are really anxious to get the results and they don't get them right away. It can take a week or two or more for your pap.
Yeah.
And then sometimes people get the results of their blood work or their pap smear even before their doctor or nurse practitioner or physician assistant even has a chance to take a look at it. And so you get a lot of those, which really kind of slows your day down and makes extra work. So do you have any words of advice about patients taking a deep breath and waiting and not jumping on the gun too fast?
Yes, I always just say there's nothing wrong until there's something wrong. So yes, we'll. A lot. I'm even one of those people. I'll get my results back, and I'm like, "What is this? Oh my!" And then and then I'm like, "I need to message my office, but it's Saturday night, so either way, I still have to wait a moment." I do say stay away from like Dr. Google because they are not always reliable, and it is frustrating to have to wait. You should get a response back when you get results, especially like abnormal results, back within at least 2 days. If it's urgent, you will get a call back like very soon, like very, very soon if there's something critical. We actually get notified if there are critical labs. So in the event that something is like super critical and an intervention needs to be done right away, we would be jumping on that like immediately. We get a call, we have to respond within like a certain amount of hours, and I mean like single digits, like I think it's like 2 or 3 hours. So we would definitely get on that. Otherwise, it can take about like a day or two for the physician or the nurse practitioner to get back to you with those results.
And a lot of times I know when I get the messages, well, the patient wants to know what you think about a lab value that's just slightly outside of normal range. I haven't even looked at it yet because I'm seeing a full day of patients, right? Because if it is a lab critical value that's life threatening, then the lab calls us and we have to deal with it right away. So most of the time, thankfully, it's not that. And sometimes we just like to wait till we have all the results back to get the full picture to say this is what you need to do. And most of the time, if you're getting a comprehensive evaluation, you should already have a visit either in person or virtually to go over those results and not expect that the health team is going to just drop everything for just minor changes that are not emergency. The flip side of that is, though, I have some women who are real chill and real relaxed and they're like, I never heard anything, so I thought it was fine. I mean, everybody should always get reports of their PAPs, of their ultrasounds, of their blood work. And if you don't hear back, maybe you're in a healthcare system that you're listening that doesn't have my chart and that electronic documentation and communication. Maybe you're in a private practice or it's a send out lab. And I do think that as an individual patient, you should have that responsibility to make sure that the ends are everything's wrapped up. So one common abnormality, especially in women over 50, is getting a pap smear that shows atypical squamous cells of unknown significance, so-called ascus. And if the HPV, either direct or reflex, is negative, meaning you don't have the virus that's associated with precancer or cancer of the cervix, it's just atypical cells without the virus. I know you get lots of questions about, I want to get my pap smear again right away, or why do I need to wait a year?
Yeah, because what people don't know is that like those Oscar cells, it can be a direct like result of vaginal dryness, menopausal hormonal changes, having intercourse, having any type of like infection, like maybe BV, which can resolve on its own from time to time, yeast infection. If you do have any like STIs or STDs, that can cause some atypical cells there. But a lot of time we don't like to just keep repeatedly going in unnecessarily, billing you. We don't like to do things in like be invasive when we do not have to. Like the ACOG guidelines do say it's safe to wait a year, follow up on a year with those, especially not with the HPV infection, because the HPV infection is what generally will cause that cervical cancer, not those atypical cells itself, because atypical can happen from almost anything. Almost a sneeze can give you atypical cells.
Yes.
But
It's very common.
it's
And
very
for those women that are in the menopausal range, even if they're not feeling vaginal dryness or pain with sexual activity or bladder overactivity, I will always prescribe either vaginal estrogen or vaginal DHEA for at least 2 months straight before you come in for that repeat PAP. There are some clinicians that will say, you can wait 3 years. I think that's too long personally, just like I think 5 years is a little bit too long. And, people change jobs, they might move, they have different healthcare insurance. I just think it's too long a period of time. But our nurse practitioners are really good. They'll get you you in within a year, but you have to take the responsibility as the patient and do that, whatever that vaginal treatment is. And for those women with common minor vaginal irritations and conditions like bacterial vaginosis BV, yeast infections, we've had prior podcasts on that. You can go on speakingofwomenshealth.com and under the search button put BV podcast or just BV or vaginitis or vulvar care. Those are some of our most searched read information.
Yeah.
The next question, as we're starting to wrap up, is can my women's health nurse practitioner physician adjust my dose of hormones or oral contraceptives just on their own without an appointment?
No, yeah, you definitely need an appointment because we have to get further evaluation from the nurse practitioner and physician. So if you feel like you need an adjustment, that tells us that something's wrong, like something's going wrong, or you're still feeling some symptoms. So we need to dig in deeper a little bit and see what's the cause of those symptoms. Like we have to check some lab work. We have to talk to you, know what we need to order. We have to see what else is going on. So it's really important to have like another visit on the books before we get any further blood work, and then before we adjust any dosages, because you may not need an adjustment. You just may need a change in therapy altogether. But we won't know that until you see the doctor or the NP.
Mm-hmm. Yes. And that kind of also goes along with people wanting new hormone regimens. I mean, maybe they have a new medical problem. Maybe their thyroid hasn't been checked. Maybe their blood pressure's too high for certain types of regimens. There's so many different factors that can be taken into effect. I think the other question that comes through a lot is, I think I have an infection. It seems like the one I had before, and I just want a prescription. I don't want to come in, or I don't want to go to urgent care. Will you just give me the antibiotics now? I mean, I know you get those questions.
Yeah, that one too, yes. And the reason why we can't just give an antibiotic again is because, well, it is an antibiotic, and we don't want to treat you with the wrong treatment when it could be something else. Some of these like symptoms that one may have, like the itchiness or like the irritation, it could be an infection of yeast, it could be an infection of bacteria. We wouldn't know until after we test you. We want to ensure the proper treatment for your safety, and we don't want you to have any type of like a tolerance to the antibiotic or a resistance to the antibiotic they use because you're overusing it, thinking that you have this recurrent BV. So yeah, we always recommend coming for an appointment.
That is really the best advice. And what I tell women who've been evaluated and know in the past they've had BV or yeast infections or maybe bladder infections like after sexual activity, assuming they've been previously evaluated and they're a stable patient and they know they're going to go on a cruise or they're going to be away, you can ask at the time of your annual visit, whether you're getting a PAP or not, because maybe you need one, maybe you don't. That's the time at the annual visit to say, can I have a prescription that I can just have on hand? Okay. But when you call in with new symptoms and new problems, we're obligated to do a new evaluation. And so I think that's a little bit of inside information, and that might be a way for women who truly have already been evaluated. But it's not fair for the triage nurse or the covering physician or covering nurse practitioner who doesn't have a relationship with the patient to be just demanded that they get a prescription. And I know that that's an uncomfortable situation that sometimes that you're involved in. And the other issue is when women say, I want to get an appointment right now, but they say I have to wait 3 months. What advice do you have for those women?
So if the provider that you prefer to see is completely booked up or booked out, we have a team here. Yeah, we have a team. And depending on what you need, we can refer you out to the other providers on our HI team here. That can see you and that can help treat you if you need anything and evaluate you and assess your symptoms.
So you're saying that you might not get to see the person that you want to see, but if you're flexible and it's urgent, usually you can get an appointment either in person.
Yeah, there's some providers that have a little bit of a sooner availability than others, still building up their patients and clientele here. So
yes.
And they're completely confident, knowledgeable, and they can treat.
Well, thank you so much, Marissa, and you are such a gem, and I really appreciate you joining us on this Speaking of Women's Health podcast, and I want to thank our listeners for tuning in. We're so grateful for your support, and we hope that you'll support our podcast, share it with others, forward it to your friends, leave us a 5-star rating. You can even donate on our speakingofwomenshealth.com site. And to catch all the latest from us, make sure you subscribe. It's free. Just hit the follow button anywhere you listen to podcasts. Apple Podcast, Spotify, TuneIn. That way you won't miss any future episodes. And we'll see you next time in the Sunflower House. Remember, be strong, be healthy, and be in charge.